neuroectoderm, absorb the light and transform it into an electrical impulses that transmitted through the optic nerve toward the brain. Originating from the neuroectoderm, extend from the optic nerve till the ora serrata anteriorly, formed mainly by two layers, a neural layer and the retinal pigment epithelium layer. Includes visual and non-visual sensing neural cells. This is an illustration of the globe in general, and you can see there are three main layers forming the globe: the outer layer, the intermediate layer, and the inner layer. Inner layer, it is a retinal layer. Intermediate layer, which is mainly for nourishment, and it is called what? What is called the intermediate layer of the globe?
Sclera.
What is it?
Choroid.
Yes. So in general, it is uveal tissue, and the uveal tissue or the uvea. طبعا هذه لها علاقة باللكشر الثانية اللي راح تكون عن طريق عن اليوفيايتس اللي هو اليوفيال tissue. Uveal tissue forming three main parts: choroid, ciliary body, and the iris. The outer layer, which is for what? Protection, and includes what?
Sclera and cornea.
Excellent. So mainly with the sclera, and this is for protection. Cornea for what? As what? As a refractive index tissue. Excellent. Lena, as for refraction. طيب, the inner layer, and this is forming what? The retinal layer. Retinal layer is formed anatomically. We can divide it into the center, which is the macula, and the periphery, which is till the end of the retina in the peripheral region, which is attached into the varus plana of the ciliary body. That's what's called the aura serrata. طيب لو نرجع في السلايد الأول اللي هو we said about it extends from the optic nerve till the aura serrata. So the aura serrata, it is the end of the retina and the start of the varus plana, which is the first layer or the first part of the ciliary body. تمام؟ طيب, histologically it forms by 10 layers, starting from the inner limiting membrane, followed by nerve fiber layer, followed by the ganglion cell layer, then the inner plexiform layer. Inner plexiform layer, it is interconnecting the end ganglion cell layer with the inner nuclear layer, and the inner nuclear layer, which is formed by the bipolar cell, and then outer plexiform layer, which is interconnecting between the inner nuclear layer and the outer nuclear layer. The outer nuclear layer, it is the main cell that is sensing the light, either in dark light or in bright light. Okay, so the outer nuclear layer formed by the rods and the cones, and then after the outer limiting membrane, inner outer segment of the rods and the cones. This is very important as clinical application, and followed by the last layer, which is the pigmented epithelium layer. So the pigmented epithelium layer and the neural layer, يعني لو نرجع للسلايد الأول اللي هو قلنا إنه the retina is formed by what? By two main layers, neural layer and the retinal pigment epithelium. So we go back now histologically. The neural layer formed by 9 layers, and then retinal pigment epithelium. أيوة, وش السؤال؟
معليش ممكن تستخدم بوينتر بعد إذنك.
بوينتر الحين واضح؟ واضح الآن ولا لا؟
واضح دكتور.
Okay, ممتاز. So these are the layers forming the neural layer, then followed by the retinal pigment epithelium. This is light microscope showing the layers. Okay, so this is a ganglion cell layer. This is the inner nuclear layer, and this is the outer nuclear layer. Outer nuclear layer, it is the main part sensing the light and dividing by the cells into rods and the cones. Okay. نجي الآن على اللي هو We will take the outer nuclear layer, which is very important, and formed by two cell type, two photoreceptor cell type. One, the cones, and the other is the rods. Rods and the cones named because of the shape of the outer segment So the outer segment here is like a cylindrical shape. That's why it's called cone. And this is like, it's a triangle, so that's why it's called the cone. So this is the cones and this is the rods. The difference between the rods and the cones, rods mainly for the dark light and does not sense the colors. So only it is a monochromatic visual perception. Cones, it is for bright light. It is responsible for the sharp vision, and it is responsible for the color vision. So it is a multi-chromatic. Okay, so these are the main difference between the rods and the cones. Why this is important? Because some of the retinal dystrophies, which is a congenital progressive retinal degeneration, sometimes it is involving only the rod. And the main example of it, which is, what is the most common retinal dystrophy in our country? No, diabetic macular edema. Diabetes. Yeah, this is not a congenital. Color blindness. Yeah, this is common. Retinitis pigmentosa. Excellent. So retinitis pigmentosa involving which cell? What is the cell that is affected in retinitis? Yes, excellent. So that's why the sharp vision, the central vision in this patient is intact. And the color vision is intact. But what happens? They will have what? What is the main symptom they present? They present with what? Excellent. So nyctalopia or night blindness. اللي هو العشاء. This is retinitis pigmentosa. It started with rods dysfunction. طيب? So that's why they will have a dark vision adaptation problem. They will have a night blindness. They cannot see in dark light at all. طيب? Okay, so this is a basic. Now we are going into retinal disorders. Retinal disorders, we can divide them based on the etiology into vascular, degenerative, congenital, as well as neoplastic. We'll start with the vascular entity, which is very important in our country. Diabetic retinopathy, which is the main important vasculopathy in the retina. Diabetic retinopathy defined as a progressive dysfunction of the retinal blood vessels caused by chronic hyperglycemia. There are many causes. One of them is just the underlying cause is hyperglycemia, but they have an inflammatory component. Diabetic retinopathy can be a complication of diabetes type 1, type 2, or gestational diabetes. Initially, it is asymptomatic, and that's why the screening protocol in diabetic retinopathy is very and crucial factor in preventing blindness in our country in relation to diabetes. If not treated, it can cause actually blindness. Risk factor of or for the severity of diabetic retinopathy, including the duration, which is the most important factor, followed by poor blood sugar control, followed by coexisting disease. Coexisting disease like what? Like hypertension, dyslipidemia, anemia, pulmonary disease, anything that is related to poor oxygen level in the body, as well as barrier to care, which is deficiency in the screening protocol. طيب. Pathophysiology, diabetic retinopathy is a microvasculopathy that causes retinal capillary occlusion as well as retinal capillary leakage. In order to know what happens in diabetic retinopathy, we will go through the stages, and then we can go back to the pathogenesis. Stages, we can divide them clinically into non-proliferative and proliferative diabetic retinopathy. Proliferative, non-proliferative, if there is abnormal proliferation over the surface of the retina or in the iris, which is called neovascularization in the iris or rubiosis iridis, and this is called proliferative diabetic retinopathy. And the main complication of proliferative diabetic retinopathy is vitreous hemorrhage, which is a very common presentation to emergency department of these patients. They will present with a painless loss of vision, either vitreous hemorrhage, traction detachment, or combined traction plus rhegmatigenous retinal detachment, which is the end stage of diabetic retinopathy. All of our screening protocol, we need to prevent the patient from entering this stage. Okay? Vitreous hemorrhage, it is self-limiting. It can resolve by itself without any intervention. But in traction detachment, this is needs surgical intervention. If it is progressing to traction plus rhegmatigenous retinal detachment, this is the most worrisome and bad prognosis in these patients. Non-proliferative diabetic retinopathy, we can divide them into stages. We'll go through them now. But the main important presentation, if the patient will present with MBDR, is the diabetic macular edema, which is very common. This is a fundus photo picture of a patient with a normal retina. You can see normal appearance of the retinal tissue, and this is the macula. This is part of the macula, and that's why we mention in the retinal anatomy we can divide the retina into the macular and the extramacular. And the macula is divided again into the fovea and the extrafovea. Okay, the fovea, the parafovea, and the extrafoveal, the perifoveal, the juxtafoveal, all of them were almost the same. But what you have to know there is a macula which is forming around 6 millimeter in distance between the optic nerve till the periphery, forming around 6 disc diameter and 6 millimeter in length. And it is located temporal to the disc. And this is which eye, based on this appearance? Excellent. So it is the right eye. Excellent. So this is the normal appearance of the retinal vessels. You can see the large caliber and the dark, this is a vein. The more straight one and lighter in color, this is the artery. So it starts with the central retinal artery and then dividing it into superior and inferior. And superior divided into superior temporal, superior nasal, inferior temporal, inferior nasal. And the vein, it is the same. So this is the superior temporal retinal vein. This is inferior temporal retinal vein. And then it is branching all over. You can see the whole retina is full by the vessels except the fovea. So the fovea, the vitreous in front, the lens in front, the cornea in front, and the tear film in front of the cornea, it has to be very clear. It's called crystal clear structures. And why is that? To allow the light to pass without intervention. And this is the responsible for the excellent, sharp visual acuity. And any disruption in this area, it will affect the vision. And that's why the patient with diabetic macular edema, like this picture, this is a fovea. This is what's called optical coherence tomography. It is one of the imaging study that we use it very commonly in the clinic in retinal department. We'll go back actually here now to see the difference. This is which eye?
Left.
Excellent. So this is the left eye, this is the optic nerve, and this is the nasal part, and this is the temporal part, and this is the macular area. What you can see here, you can see it's abnormal. There is a difference between this one and this one. This is very clear. Very clear and very clean retina, and this is no, there is abnormality. What abnormality you can see? You can see there is a deposit, yellowish deposits, and you can see there is a reddish deposition in the retina. And this is what's called dot plot hemorrhages, and this is what's called hard excision. And we have also soft excitation we are seeing commonly in microvascular occlusion, most commonly in hypertensive, in some rheumatological disease like SLE, and in some viral condition like HIV. So these are the most important actually hard excitation related, soft excitation related retinal changes. So what you can see hard excitation here, dot blood hemorrhages here, and you cannot see the micro. This is microaneurysm, and in this stage we need to do what's called optical coherence tomography or OCT, and this is the OCT picture that's showing of the same patient, that's showing a cystic spaces and elevation of the fovea. We will take this image from down to up, and this is after treatment, and this is at presentation. You can see the cystic spaces, the fluid-filled spaces in the retinal tissue, and you see also the subretinal fluid here, which is a very severe one. In this stage, we treat them with what's called anti-vascular endothelial growth factor injection. So it's intravitreal injection inside the eye. We are injecting the patient monthly for almost 3 to 6 doses. For example, we are injecting today, and then after that by 4 to 6 weeks, and followed by 4 to 6 weeks. So most of the cases, they improve like this one and regain the what's called near normal architecture of the retinal tissue. Okay. Any question about this one and the previous one? So here, still we are, which stage now, based on this photo? And again, now we have 2 stages. Excellent. So either none. Excellent. So we have 2 stage. Again, we have 2 stage, MBDR and BDR. Here we are still in the MBDR phase, and we said about MBDR, what is it? What is the common presentation? Is the diabetic macular edema, and this is the diabetic macular edema and the treatment option of it. Okay. طيب. The other stage is the proliferative diabetic retinopathy, which is the advanced stage. You can see this is which eye? Left or right? Who said Lena? Lena قبل شوي جاوبتي انت صح. Left or right? Lena? Okay, so it is the right eye. This is the optic nerve, and this is the temporal. This is the macular area. What you can see there is a fibrosis. There is a whitish structure that is in front of the retina and pulling the retina. You can see that the disruption in the foveal area, in the macular area. The macular area is not so smooth here. Okay. So this is the advanced stage. This is what's called the tractional retinal detachment. Why it is detachment? Because there is fibrosis, and it is this one. Okay, so it's not scar. It's not related to trauma. It's not scarring. It is proliferation actually. This stage اللي كنا فيه تو ثواني. This stage, الfibrous. You can see, yes, there is scarring behind the retina here, behind this fibrosis. You can see these dots. These dots as a result of laser scar. In this stage, it didn't start like this. It starts with a new vascularization, new vessels that is building over the disc and growing all over. And then the patient present late. And then at that stage, we did full ban retinal photocoagulation. The residual ban retinal photocoagulation, it will it will shrunken the blood vessels, but remaining the fibrous tissue. In general, if there is abnormal proliferation of the blood vessel, there is two components: the vascular component and the fibrous tissue component, which is the supporting tissue, which is the connective tissue. So the connective tissue, it is around the blood vessel. The blood vessel, it will shrunken, it will disappear, it will vanish after the laser treatment. Okay, but we are remaining now with this fibrous tissue, this fibrous proliferation. It is affecting the retina now. It is affecting the macula. It is pulling the macula. It is distorting the vision. It is distorting the fovea. So in this stage, we can go, and this stage what's called the tractional retinal fibrosis, proliferation, detachment. All of these are the same, but this is tractional diabetic retinopathy. Okay. If this traction results in a break, and this break bringing the fluid inside and detaching the retina, this is called combined tractional rhegmatogenous retinal detachment. rhegmatogenous راح نجيها بعد شوي، ولكن the name of rhegma, it is a Latin name and it is given for a break. Rhegmatogenous, rhegma, it is a break. Retinal detachment, it is separation of the retinal tissue from the underlying retinal pigment epithelium. طيب نجيها بعد شوي مع retinal detachment. At this stage, it's a surgical stage. So we go for doing a procedure that's called a parasplana vitrectomy plus membrane peeling plus endolaser plus tamponade, either air tamponade, gas tamponade, silicone oil tamponade, either light or heavy, and then need a removal afterward. This is a real picture of a patient that we are doing for him a parasplana vitrectomy. What is parasplana? Why it is parasplana? We mentioned in the start of this lecture about the ciliary body. And the ciliary body, the location is around 2 millimeters from the iris, from the limbus. Okay, so the limbus is a very important surgical, anatomical, structural landmark in the eye. We depend on it in the surgery. So this is the limbus. The limbus الجزء الواضح يعني قدامكم هذا. This is a cornea, this is the end, and this is the start of the sclera. Okay, so between the limbus, in general, the ciliary body is around 1.5 to 2 millimeter. We are going behind it around 3.5 millimeter from the limbus, depend on the age of the patient. And this is a location exactly of what? Of the parasplana. And why we are going for a parasplana, we'll go back just for once. We'll go here. Okay, so this is the ciliary body, and this is the iris. This is the suspensory ligament and the zonules, and this is the pars plicata, and this is the parasplana, which is part of the ciliary body. The parasplana, it is avascularized area. That's why in the surgery we are going through this area. We are putting the instrument and the endoscopic instrument, and then we are doing the vitrectomy here and removing the membranes. So that's why we choose. That's why it has been chosen. This is the excellent area to go through and do the retinal surgery. Is it clear? So that's why it is called parasplana vitrectomy, because we are removing the vitreous. Membrane peeling, because we are removing this membrane اللي كان موجود هنا هذا membrane. So that's why we mention about membrane peeling, and endolaser because we are doing some laser inside. So this is a picture illustration of the surgery. The most important thing for your level is the screening protocol. And the recommended eye examination screening protocol for diabetic patient depend, is it type 1, type 2, or type 1, type 2, but before pregnancy, because pregnancy is what? Diabetogenic condition. Okay. So in type 1, we are examining the patient after 3 to 5 years from the diagnosis, because why? Any justification? Why we are examining the patient in type 1 later than type 2? Excellent. So early diagnosis. Most of the patient type 1, they will present early. And they will present with what? With the complication of type 1, which is most likely it is coma. Excellent. Decay and coma. Excellent. Type 2, at the time of diagnosis. Why? Because most of the time, it's a late diagnosis. The patient will present late in the course of the disease. Prior to pregnancy in type 1, type 2, prior to conception, early in the first trimester. This is the recommended follow-up of the patients. كلهم yearly. Pregnancy is a special condition, need more elaboration. It's beyond your scope now. So the treatment for diabetic retinopathy, the most important is prevention, and preventing by what? It's called the secondary prevention. It's not the primary prevention. We are dealing with a complication. We are dealing with a complication of what? Of the diabetes. So we cannot prevent diabetes at this stage. We are preventing the complication of diabetes. And that's why it's called the secondary prevention. We are preventing the patient from entering into a complication. And the main complication of diabetes are what? What are the most common complications of diabetes in general in the body? It's a microvasculopathy, yes. But what are the most important organ that is involved in the diabetes? Yeah, diabetic retinopathy, excellent. What else? Kidney, excellent. Yeah, okay. So the things that we are seeing in the retina, it is the same that is happening in the renal counterpart. So that's why they will have what? They will have renal failure because of what? Fibrosis. Okay, so it is, and that's why I mentioned diabetic and diabetes in general. It is not a poor glycemic control only. It is not only a poor glycemic control. There is an inflammatory condition involving the diabetes in the body. And that's why sometimes we are injecting the patient with steroid in the eye to treat diabetic retinopathy and diabetic macular edema, which is chronic and does not respond to the regular anti-VEGF that we are giving. I will elaborate more about here, about the anti-VEGF that we are giving to the patient. We are giving almost, there are many options, starting with Avastin, which is a bevacizumab. You will hear this name in oncology. The other medication, it is Lucentis, which is the ranibizumab. And the other medication, which is the most common nowadays, is the Eylea, which is aflibercept, followed by steroid injection. Sometimes you are injecting this patient with steroid. For example, if we inject this patient with a regular anti-VEGF injection like Avastin, Lucentis, Eylea, and does not respond well, and this is it's not uncommon. 50% of the patient, they wouldn't respond to the conventional treatment. Then at that stage, we are jumping to steroid injection. And we notice a great improvement after injecting the patient with intravitreal steroid. And it's called Ozurdex implant. It is an implant, takes around 6 months to resolve. طيب. Any question about diabetic retinopathy? Okay, we are going now for the second subject, which is hypertensive retinopathy. Still, we are in the vasculopathy stage. What is the basis of using steroid? This is an option, and based on the studies, proven that mainly the steroid is a treatment option in retinal vein occlusion. It is the mainstay, actually. It is the first option. The other indication is the diabetic retinopathy. The other indication is uveitis, chronic special type of uveitis, which is intermediate uveitis, after ruling out infectious infectious causes. Followed by these are actually followed by post-operative macular edema. Sometime we are using it, but this is based on the study, based on the evidence-based practice. طيب, hypertensive retinopathy. It's a clinical term that refers to the fundoscopic signs that is present in the patient who having hypertension. Microvascular process that leads to the following vascular changes like vasoconstrictive phase, exudative phase, and then the sclerotic phase. Hypertensive changes without arteriolosclerotic changes in the case of secondary hypertension, most commonly pregnancy induced, which is called what? What is a condition if the patient is having pregnancy and hypertension? Excellent. So preeclampsia and eclampsia, it's a very important condition that is resulting in a severe hypertensive retinopathy. It wasn't, I think, mentioned here, resulting in a choroidal infarction and resulting in exudative retinal detachment. It is a very common condition to have it with preeclampsia and eclampsia especially. And it is a self-limiting. It resolves by itself. It takes around 3 to 6 months to resolve spontaneously. I published one case report regarding this condition. Hypertensive retinopathy, ocular findings. These are the chronic findings. Optic nerve swelling, edema. This is acute, and this is a very severe hypertensive retinopathy. Retinal ischemia, neovascularization. It is in the later stage. But we can divide the hypertensive retinopathy into two subtypes. These are the complications, and these are the features of the hypertensive retinopathy. The features like the AV nibbing or AV nicking, cotton wool spots or the soft exudation اللي قلناها قبل شوي, retinal hemorrhages, and these are the signs of a chronic hypertensive retinopathy. We have the signs of acute hypertensive retinopathy, which is the optic nerve swelling. The optic nerve swelling, it's called what? انتم اخذتوها في النيورو يمكن او neurology. If the patient is having optic nerve swelling, what it's called? It's a very important, excellent, papilledema. Excellent, excellent. So if you have papilledema, let us say 30 or 40-year-old male or female present to ER and complaining of period vision, you did a direct ophthalmoscope and you saw optic nerve swelling. What you will do next? You will label this patient as papilledema. Excellent. So you will think about the brain direct. And here you have to change your mind a little bit. So hypertensive retinopathy, it is one of the common causes of papilledema. So simple, take the blood pressure before going for the advanced investigation. Sure, you have to rule out papilledema secondary to increase intracranial pressure, whatever the space occupying lesion or other causes. In addition to that, there is a misleading condition, what is called optic nerve swelling without edema. There is no fluid, but is a misleading. You will examine the patient. You will see with direct ophthalmoscope. You will see an elevation of the optic nerve. You wouldn't label this patient as papilledema except after you diagnose this optic nerve swelling secondary to the increased intracranial pressure. Otherwise, it is not papilledema. It is swelling. And the optic nerve swelling, it can happen with many causes in ocular condition. starting with inflammatory causes and ending with what's called pseudo-papilledema, which is pseudo swelling. And this is very common in hyperopic patients, especially in young patients. They will have optic nerve swelling without edema, no fluid. We can diagnose it. As ophthalmologists, we can differentiate between a true edema and a pseudo edema. And based on that, you will go through the following investigation. طيب. The complications of hypertensive retinopathy, starting with a branch retinal artery occlusion, which is not common, branch retinal vein occlusion, which is the very common complication. If it happens in hypertensive, this is a condition that it will happen. The branch vein occlusion is the most common, followed by central retinal vein occlusion, followed by retinal artery macroaneurysm. So occlusion, either venous or artery, and macroaneurysm. And the macroaneurysm, it can end up with leaking macroaneurysm, ruptured macroaneurysm, or just a macroaneurysm sitting down there in the retina and doing nothing actually. And these are some pictures. This is which eye? Which eye? Excellent. Left eye. So what you can see here? You can see the retinal structure or no? You cannot see. So, excellent. Nora, excellent. So, hemorrhage, yes, excellent. Also, there is no details of the underlying retina. So, you can see the blood, there is a hemorrhage that is obscuring the whole retina. And this is what? Central retinal vein occlusion. The difference between vein occlusion, like this one and like this one, and the artery occlusion, there is a difference. There is a hemorrhage, and here there is nothing, no hemorrhage. You can see just a whitening, and it is called the ischemic whitening. And you can see here the sclerotic artery. This case was giant cell arteritis. It is very common to have a ciliary artery occlusion. Sometimes giant cell arteritis can result in what's called anterior ischemic optic neuropathy or optic neuropathy. It is a very severe condition. And the most important complication of giant cell arteritis in ophthalmology, it's a blinding condition actually. It can result in non-improving and non-reversal of ischemic optic neuropathy, followed by central retinal artery occlusion. طيب, this is central retinal vein occlusion. This is a branch vein occlusion. You can see the hemorrhage and the exudation, and taking the shape of what? Of a sector. Why it is sector? Any explanation? Why this one is a diffuse and this one is sectoral only? What's called wedge shape. Excellent. Excellent. So going to the territory of the vein. Excellent, Abdullah. This condition is ruptured macroaneurysm. You can see this is a macroaneurysm, and this is ruptured macroaneurysm. In the ruptured cases, you can see the blood that is coming to the retina. It's a multi-layered. It's going in the retina, and it's going subretinal. Why this one is black, jet, and this one is reddish at the same timing? What is the difference? Why? And why here is just a reddish area? No. And that's why no. And that's why I said it is in the same timing. And that's why I said it's a multi-layered hemorrhage. Multi-layered hemorrhage, excellent, Maha. Yeah, excellent. It is under retina. So under RBE actually. It is behind the retinal pigment epithelium. And that's why it is a jet black here. And that's why we said it is what? It is a multi-layered hemorrhage. The hemorrhage in the retina, it can comes in front of the retina, which is pre-retina. It can comes actually in the vitreous. If anatomy, if we go back, if you go back here, as an anatomical structure, the hemorrhage, it can result, it can happen where? Here, in front of the sclera. What is called? What is called if it is under the conj? Subconjunctival, excellent. If it is in the anterior chamber, what is called? What is the name of the blood that is present here? Excellent, hyphema. If the hemorrhage is coming here, what is called? In the vitreous space. Excellent, vitreous hemorrhage. So in the retina, we having a pre-retinal hemorrhage here. Pre-retinal hemorrhage either under the limiting membrane, which is the under eye limb hemorrhage, separating the eye limb from the underlying tissue. And sometimes it is subvitreal hemorrhage. So the vitreous, it is attached to the underlying retina. Hemorrhage, it can result between the vitreous and the retina, which is called subvitreal, sub-eye limb hemorrhage. And this is sub-eye limb hemorrhage is very important in what? In a Valsalva hemorrhage. Okay, in a Valsalva maneuver. Okay, and this can result in a hemorrhage, sub-eye limb hemorrhage. It takes a long time to resolve. Sometimes we need to do a YAG laser to break it and to make this fluid going through the vitreous and resolve by itself within 2 to 6 weeks. Okay, and if it is in the retina, it is an intraretinal hemorrhage, like in diabetes and in hypertensive, and it can result in subretinal hemorrhage, separating the retinal layer from the retinal pigment epithelium. هنا يعني. Okay, so this is subretinal hemorrhage. It can result in sub-RBE hemorrhage, and in this stage you can see it as a jet black. And sometimes it results in a choroidal hemorrhage, and this is very debilitating condition. It's a very worrisome, very bad prognosis if the patient is having what's called a suprachoroidal hemorrhage. It is behind the choroid, between the choroid and the sclera. This is the most severe complication after any ocular surgery. Invasive ocular surgery, not LASIK يعني ولا شيء. لكن invasive ocular surgery, yes, it can يعني الحمد لله انه it's extremely rare, لكن it can happens less than 1%. طبعا لها risk factor معينة, ولكن happens. I saw 2 in general ophthalmologists, you can see 1 or 2 in the whole life. I saw till now 2 cases that happens during the fellowship training. طيب. Treatment option, it's a multidisciplinary action. This is what? طبعا مكتوب يعني. Okay. طيب. Anyone can describe? إذا كان بالمايك يعني أفضل. أتوقع إنه بطول. Description. يعني diagnosis موجود. لكن in description يعني لو جاكتكم مثلا philosophy exam and describe what you will say as a description. دلال مثلا آخر واحدة جابت. Okay. Yeah, anyone can take the mic. مفتوح المايك عندكم ولا؟ علي؟
أقدر أقول this is a fundus view of the retina, and I can see superior sectoral hemorrhage obscuring most of the superior part of the retina.
Okay.
Secondary to retinal vein occlusion.
Excellent. So you can mention this is a fundus photo of the left eye, centered to the macular area and the optic nerve, showing retinal hemorrhage that is involving the sectoral part. As you said, it's a superior temporal. There is no full picture. Either it is called the hemi-retinal vein occlusion or branch retinal vein occlusion. The difference, hemi-retinal يعني ماخذ كل نص الرتنا all over up. يعني involving the cause is the superior branch of the retinal vein هنا يعني. طيب at this level this is most likely I think it is a large tributary of the most likely to superior branch, so it is a hemiretinal vein occlusion. عموما it's a retinal vein occlusion. Okay, hemiretinal, it's under the branch, so if you mention this branch vein occlusion, it's excellent. If you mention this is hemiretinal vein occlusion, it is excellent also, the same. أهم شيء إنها ما تكون central vein occlusion. Okay, لأنه different and difference in the complication, the treatment option. طيب هنا in description from the female side, describe. Anyone?
Ischemic whitish.
دلال أيوة, describe fully.
Ischemic whitish of the retina.
No, describe fully. يعني قصدي إنه this is a picture of the right كذا يعني هذا.
Okay, this is a picture of the right retina, and there is ischemic whitish near or above the macula.
Okay, so it's a branch macular artery occlusion أو branch artery occlusion, and this is يعني branch retinal artery occlusion. طيب أو branch macular if you want to be specific. طيب in this condition دلال, what you will do? أيوة دلال, what you will do? طيب you label this patient as retinal artery occlusion. What you will do next?
كسيرجري يعني أو كانترفنشن قصدك؟
اي يعني جاك في الإيار مثلا
أو
في العيادة.
investigation يعني.
Up to you. What you will do next?
Check her blood pressure.
Excellent. So hypertension results in artery occlusion. Excellent. What else?
Control.
What is it?
Glycemic control.
Glycemic control. طيب diabetes can result in artery occlusion. It can, but it is extremely rare, but it can be.
Yeah, it's
Excellent.
Okay,
ممتاز. طيب في other elaboration رنا. Excellent. So hypertension is the most important. You need to rule out. Rana, you mentioned a good thing. Rana. أيوة speak please. وش كتبتي تو؟ Rana, you can talk. طيب. طيب, can you mention it again in the chat? Sarah?
Okay. We look for the underlying disease like thromboembolic or hypercoagulable state. So we check if the patient have arterial fibrillation or carotid stenosis like Rana said. And we do ECG or carotid Doppler, I think.
Excellent. So this is a full answer. This is very important. There is a relationship between the ophthalmology and the systemic disease. And sometimes it is a very dangerous disease, underlying condition that you need to rule out. It might be you are the first one who is facing this patient. You are the first one who will diagnose this patient. So if the patient is having atrial fibrillation, maybe the next episode is the stroke. This is branch artery occlusion. It wouldn't affect too much in the vision, but in the stroke, if it's coming to a crucial part in the brain, it will affect him. Sometimes yes, carotid artery stenosis and carotid artery atherosclerosis, which is very common in diabetic patient, dyslipidemic patient, hypertensive patient, all of these. So what is carotid Doppler? سارة اللي تو قبل شوي.
For diagnose carotid stenosis?
Yeah, mention about what is carotid Doppler. Is it CT scan, MRI, what is it? Excellent. It's an ultrasound. So
I
it's a
think, am I wrong?
modified ultrasound. No, it's ultrasound. It is an ultrasonography. It is modified to know the flow of the artery and the vein in a specific region. And الدوبلر عموما يستخدم في أشياء كثير، من ضمنها الكارت الدوبلر، من ضمنها الدي في تي and the leg. Sometimes you are using it in varicose vein, no, in DVT, in deep vein thrombosis. So the underlying condition in artery occlusion is very, very important. في another investigation, which is what I mentioned during the talk before. What it was? I mentioned pathology, rheumatological pathology, that it can result in like this picture. اللي مركز مين كان مركز قبل شوي؟ السلي. Yes, excellent. Else. السلي طبعا does not result in vascular occlusion. It can result in what? Cotton wool spots. It's a micro occlusion in the nerve fiber layer. Polyarthritis nodosa. I didn't mention polyarthritis nodosa. Rheumatoid arthritis, I didn't mention it. No. Macrocell arthritis. ما هو macrocell. There is another one. Yes, giant. Excellent. So giant cell arthritis is very important to rule out in this condition. How you will rule out? How you will rule out giant cell arthritis? What is the common presentation of giant cell arthritis? نورة تفضلي.
Biopsy.
How the patient will present?
In sudden blind.
وش بعد؟ في another common presentation.
Headache أيضا. Headache.
Yes, excellent. Headache. Headache where? In specific region or all over?
In the I think in TMJ.
What is? Don't abbreviate.
من
زمان ترى عن الأورثوبيديك يعني ما.
I think temporomandibular joint, if I'm not wrong.
Yeah, jaw claudication. Excellent. But the pain and headache is what? Is in the temporal area.
Okay.
طيب, in the head. And
Okay.
if you feel it, it is a very tenderness, and you can feel a robe-like structure. It is a thickened temporal artery. طيب. And as you mentioned, it is a biopsy to confirm it. And how you will do biopsy? Is there any special precaution in the biopsy in this disease? What is the main, what is important thing that to mention it in giant cell arthritis? Let us say you order a biopsy, regular biopsy, taken to the pathologist, and they did biopsy, and then the biopsy shows negative. You will confirm it is negative, and you would pass it. This is not giant cell, although clinically it is giant cell. Different site. Excellent, Ali. Excellent. Excellent, mashallah. So characterized by skip lesion. So that's why you have to have a long segment for biopsy. And sometimes you can take from the collateral site. Before the biopsy, what you will do? Before that. Yes, anyone? Angiography, ممكن. MRI, maybe. يمكن هذه الأشياء يعني it's a new things. ما أعرف عنها, لكن في something else that is very important. No, very important. In giant cell arthritis, if you mention giant cell serology, what is serology, Rad? هو مو serology الصراحة يعني, بس إنه في something.
No, I say maybe to check the blood if there is, because it's immune system, so we check.
Yes, if there is what?
Antibody elevations maybe.
يعني antibody إيش؟ IgM مثلا, IgG شيء?
Maybe IG G.
IgG. Okay. This is maybe it's a new thing. I don't know about it صراحة. لكن there is something else. ESR. Excellent, Abdullah. So ESR is very high in giant cell arthritis. ESR very important. ESR, platelet count, these are very important in diagnosing giant cell arthritis, followed by biopsy and the clinical presentation. Why I mention this one? If the patient presenting with like this picture and presenting with an ischemic optic neuropathy in giant cell arthritis, if you didn't diagnose him, he is blind now in one eye. If you didn't diagnose, next week he will be blind for the other eye. It's a very severe condition. So it's a red flag in our specialty. طيب, I think we mentioned the important thing. طيب. Now the macular degeneration. عموما retinal degeneration. One of the most important اللي هو macular degeneration. The most common actually, not in our community, in North American, which is the age-related macular degeneration. It's a group of disease involving the photoreceptor layer, resulting in progressive loss of their function without abnormal subretinal vascularization, with or without. As diagnostic tool, we are doing OCT, fluorescein angiography. Treatment, Amsler grid, multivitamins, intravitreal injection, طبعا. Intravitreal injection of anti-VEGF and photodynamic therapy in a condition of abnormal subretinal vascularization if it is happened with this macular degeneration. And the most important macular degeneration is the age-related macular degeneration. You need to write it down, please. So age-related macular degeneration or age-related macular degeneration. It happens in two stages, and we can divide them into two types. First is the dry, what's called AMD, and the wet, which is a wet AMD. Wet AMD if there is subretinal fluid vascularization, and dry AMD if there is no vascularization, only there is a progressive loss of the photoreceptor layer. So there is an atrophy. Okay, this is very important. Yani, if we mention about the retinal clinic, for example, and the patient will present 90% in my clinic is diabetic retinopathy, 10% is age-related macular degeneration. In North American, it is the vice versa. So age-related is 90%, diabetic retinopathy is almost 10%. طيب, like in our country, العكس. لكن this is important actually. طيب. Followed by we are talking about the anatomical changes in the retina, which is the retinal detachment. Retinal detachment, by definition, it is detachment of the neurosensory retina from the underlying RBE. Neurosensory retina from the underlying RBE. لو نجي نشوف الصور. This one, this is the neural retina, and this is the retinal pigment epithelium. There is a potential space هنا موجود. There is no tie junctions. ما في شيء يمسك الفوتوريسبتور مع ال RBE. طيب, it is a potential space, like the pleural potential space, whatever the potential space that is present in the body. Here it is a potential space, nothing. There is some mechanisms that is holding the neural tissue with the underlying retinal pigment epithelium. لكن none of them is tie junctions. And that's why, by definition, retinal detachment is what? Detachment of the neurosensory retina from the underlying retinal pigment epithelium by three main conditions. One, exudative, لما يكون في fluid. Rhegmatogenous, لما يكون في break هنا وفلويد يدخل هنا وسيبريتد. لما يكون في traction fibrosis ويسحب الرتنا هنا و tensioning it from and pulling it from the underlying retinal pigment epithelium. So this is by definition retinal pigment, retinal detachment, divided into regumentigenous, tractional, exudative, أو combination of them. Risk factor, high myopia. طبعا risk factor of what? Of regumentigenous type, which is high myopia, trauma, posterior vitreous detachment, which is common, and ocular surgery. All of these can result in detachment. Which type? Regumentigenous type. Traction مع diabetic. Exudative مع inflammatory condition. Exudative, nothing. Treat the underlying cause. Tractional, regumentigenous, needs surgical intervention. Treatment depends on the type and the cause. The surgical option that we have it, either parasplana, and we explain what is parasplana, vitrectomy, scleral buckle, we are going from outside, and pneumatic retinopexy, we are pushing just a gas inside the eye, the retinal break. طيب. This is a picture of the retina, and you can see there is a break here, which is a horseshoe break. It's very commonly associated with posterior vitreous detachment, and there is subretinal fluid, and you can see the corrugation line. This is abnormal. It's a sign of fluid that is behind the retina. So this is regumentigenous retinal detachment. طيب. The option of the surgical intervention, this is buckle. هذا اللي هو اللي قلناه قبل شوية مع surgical option اللي هو scleral buckle. الbuckle we are putting outside here. We are pushing the eye from outside. ليش? To close the break from outside inside. طيب. Any question about retinal detachment? اوكي.
دكتور
ايوه تفضل.
الباكل بيرمننت ولا؟
البكل يس بيرمننت.
تمام.
هي. طيب. طبعا في certain condition we need to remove it، بس المفروض انها permanent. لكن we remove it الا اذا كان يعني if anything that happens as a complication like erosion. يعني it can erode through the sclera with time. It can result in ischemia, and then the underlying sclera إذا كان طبعا high buckle معناتها شادين عليه بقوة يعني. And this scleral area it will be thin, and with time يعني years it will erode through the sclera and proposing and prolapsing the underlying choroidal tissue. At this stage, yes, we need to remove it as a complication يعني. لكن by itself المفروض انها ما تنشال. طيب مين اللي سالته عن الاي ام دي؟ عبد الله ولا مين؟ وش كان السؤال تو قبل؟ عبد الله اللي هو يعني. طيب we talked about the generation. We said dry and wet. What is the difference? What do you think? And we mentioned it just now. What do you think the difference? The difference طبعا هنا we mentioned about macular degeneration, and we said with or without abnormal subretinal vascularization. إذا كان في abnormal subretinal vascularization, this is wet. إذا كان ما في vascularization, what is called choroidal neovascular membrane. This is a differentiating point. If there is a CMVM, what is called the choroidal neovascular membrane, this is wet AMD. If there is no choroidal neovascular membrane, this is dry AMD, and there is special differences between them on examination. Again, this is in general talk. طيب. Okay, we are going now to the retinal dystrophies, and we mentioned about only the retinitis pigmentosa. Retinitis pigmentosa defined as a progressive bilateral retinal dystrophy, inherited or sporadic. The cardinal feature are what? Nyctalopia, اللي قلناها قبل شوي. Clinically presented with bilateral diffuse retinal pigmentation along with blood vessels, with retinal vascular atrophy and pale optic nerve, and also attenuated blood vessels. Treated with refraction and low vision aid, retinal implants. It's a new one. It was tried, and unfortunately, the company that is supporting this research went through, I think, bankrupted. So this one, no anymore present. It was done 7 cases in the ward, and King Khalid Specialist Hospital during my fellowship, it was one of them. We did, I think, 3 cases, and it wasn't successful too much. So it was just nothing actually was promising about the results. There is another condition. There is another treatment now. It's going on, which is the gene. I think stem cell transplant and gene therapy. Gene therapy was successful with one of the dystrophies, and one subtype of the dystrophies that was successful actually. And I think the future of treating the dystrophies is the stem cell and the gene therapy. It is promising, but any implants, nothing. It is useless. Actually, from the start, we mentioned it wasn't successful. Genetic counseling just to prevent the future, because it is inherited. So the family, they need to do a genetic counseling, especially with the relatives and the first or second degree relative. It is very common actually in our countries. In general, all the congenital inherited diseases, it's common in our country. This is a picture of the retina that's showing what? Black or bone spicules. It's black spots all over the retina with attenuated blood vessels, pale optic nerve, and maybe the fovea, they have escases here. بس الأوسيتين مو موجودة. لكن this is a picture of the retinitis pigmentosa. Thank you and good luck. I think we finish the first part of the lecture. Any question about it?
يا السلام عليكم. فقط سؤال.
السلام ورحمة الله وبركاته. أهلا وسهلا. مين معي؟ أنس؟
أنس. الله
حياك.
يعطيك
تفضل.
Just I have a question regarding to the diabetic patient. Let's assume that if the patient, diabetic patient comes to me and his blood sugar, let's say, more than 400 milligram per deciliter. So now I have to give him, or let's say to decrease the blood sugar to make it normal. So my question is that if إذا مثلا يعني يا دكتور إنه سويت كنترول أنا للديابيتس ونقصت not gradually يعني to the normal. Can this affect يعني الريتنا وكذا ولا؟
يعني قصدك إنه it's a rapid control of diabetes?
أيوة إيه هذا.
Yeah, excellent. It's a good actually point. Yes. In the initial stages and the initial months of controlling the uncontrolled, either diabetes or hypertension, this is not recommended. You have to control it in a staged wise and step ladder-wise fashion. Because, for example, hypertension, if the patient is having 200, they recommend that not to go down so fast because of the adaptation. And the body, and the human being عموما, it is adaptable. It's an adaptable organ and adaptable all organs, it will adapt on this condition, either the blood sugar or the blood pressure. So if you drop it down, and this adaptation, it can be decompensated and can result in stroke, it can result in MI, it can result in hypoperfusion of the end organ, it can result in an end organ damage. So in this condition, apply to the blood sugar. So what we notice as a retinal surgeon, what we notice there is a progression of diabetic retinopathy if the patient controlling the diabetes. And sometimes the patient will, many times actually, the patient will present to me in the clinic and they're having like a picture of severe NPDR with diabetic macular edema. We are injecting them and we are controlling them. Then after 3 months, he came with a controlled diabetic retinopathy. And then after 3 to 6 months, he came with worsening. And we discussed with him, he said, why it is worsening, although my blood sugar was tight control in the last 3 months. المشكلة لما تقول إنه هذه هي المشكلة بيقول كيف هذه المشكلة؟ فقعد تتكلم فيها. لكن this is yes, it is mentioned, it is seen in the practice, in the real practice, yes. So that's why it's advisable to control it not in a fast way.
كلير. جزاك الله خير يا دكتور.
حياك الله. أهلا وسهلا. I'm looking for ROP. طيب الآن السكند توك راح تكون عن retinopathy of prematurity, which is a very important topic. السلايدز موجودة shared يعني already ولا مو واضحة لكم؟ اوكي good. طيب it's a very important topic actually, especially in القصيم region, لأنه I'm working in many hospital actually, and what I saw and ROP in Qasim is very high number actually. طبعا الريتينوباثي بريماتورتي ما يعتمد just على a treatment of the ophthalmologist. المفروض this is a normal thing that has happened in the retina. This is a normal natural history and process. It has to be moving in a safe way and no need for any intervention. But this depends on the NICU care. طيب definition يعني what I noticed in قصيم it's very high in number. ممكن يعتمد على ال NICU care, ممكن يكون في number of premature babies were very high. أو ممكن يكون just as a tertiary center that is treating these patients it's only the MCH hospital اللي هو المستشفى الأطفال. لكن النمبر almost يعني within 6 months I saw around 160 patient ROP patient, and 30 to 40 of them they need intervention, and we did injection with them. 2 or 3 cases they need laser. None of them, alhamdulillah, they end up with surgical stage. We'll go now with the definition and we'll discuss about the stages. طيب defined as incomplete normal vascularization, incomplete normal vascularization of the retinal vessels, and that's why we are mentioning it about as what? As a vasculogenesis abnormality. طيب, and this vasculogenesis abnormality, it will be converted to a new vascularization. There is a difference between the vasculogenesis and a new vasculogenesis, okay? So occurs in 7% of premature babies, and only 10% of them, they need treatment. So only 7% of premature babies, they will have ROP. And only 10 among the 7%, they will have and they will need a treatment. And this is based on international studies. The point إنه any study that is published outside, it's not necessary to be applied in our country. A lot of things different. Okay, and that's why we are not taking these studies as a strict guideline. Yes, we take the benefit from it, and then we apply. ثواني. Okay, so this is a normal vasculogenesis for the babies. At 16 weeks, the blood vessels, in general, the blood vessel of the central retinal artery is coming from the ophthalmic artery, okay? So at the age of 16 weeks, this central retinal artery is reaching on the optic nerve and around the optic nerve initially. This is the whole retina. It is a white, does not have any vessels. At the age of 8 months, these vessels almost reaching till the nasal part, but still there is a crescent shape in the temporal area that was not nourished, that was not perfused by the blood vessel. From the age of 9 to 10 months, these vessels reaching and covering the whole area of the retina, temporally and nasally. This is a normal, natural development of the retinal blood vessels. طيب, and this happens intrauterine. لكن المشكلة لما يكون في delivery prematurely. This it will depend on the NICU care. If the NICU care was not optimal, or if the baby having another condition, another coexisting congenital condition, which is common to have it in these cases, this vascular perfusion and development, it will be distorted. And if the blood vessel does not reach till the periphery, and this retinal tissue is nourished only half by good nourishment and half it's not nourished, these abnormally and ischemic retina, it will produce abnormal growth factors that it will result in these blood vessels to grow abnormally, resulting in new vascularization to the vitreous, as well as resulting in a hemorrhage, resulting in traction membrane, resulting in retinal detachment. We'll go through these. Okay, so this is a basic knowledge about the retinopathy prematurity. Risk factor: if the birth weight less than 1,250 grams, if the gestational age less than 32 weeks, if it is less than 2,000 grams with unstable medical condition like having congenital disorders, if long duration with NICU admission and oxygen supplement, and the most important factor in the NICU care is the oxygen supplement. Some of the NICU care, they will have a high oxygen supplement, and this is resulting in a very poor control regarding the ROP, and this resulting in more these babies, they need treatment. طيب, this is anatomy. We'll go back to this one. and we'll go back to this stage, and we will go back to this illustration. We'll go back to what's meant of the blood plus disease after we mention about what is threshold disease. Okay, threshold disease, this is the stage of the ROB patient that is having this stage. They will need an intervention, either injection or laser or surgical intervention. Threshold disease by itself is 5 contagious or 8 non-contagious cumulative clock hours of neovascularization stage 3 with plus disease in zone 1 or zone 2. طيب. To disassemble these nomenclature, we know we need to go back now and to see what we meant about the zone. هذه 5 contagious or 8 non-contagious, this is the zones. Neovascularization, this is stage. Plus disease, this is addition. And in zone 1 or zone 2. 5 or 8, this is including with the zone. Now we'll go through it. This is a zone. Zone اللي هو if we take the optic nerve and the macula, if we take the optic nerve as the center of our field. So from the optic nerve till double distance between the optic nerve and the fovea, temporally, the same distance, go nasally, the same distance superior, the same distance inferior. This is zone 1. طيب. From the edge of the zone 1 till the end of the nasal part, and the same area, go through it till temporally. This is the whole area. This one is zone 2. The residual crescent shape temporally, this is zone 3. Extent of the disease meant by the clock hours. So if we have an ROB, for example, in this area and extending from 12 till 3, so we mentioned this is what? This is almost 1, 2, and 3. This is 3 clock hours. طيب. So in zone 1 or zone 2, ROB, whatever the stage, and going extend from this one to this one or from this one to this one. Okay. طيب هذه حسابيا نحسب اللي هي الكلوك اورز اللي هي اللي قبل شوي we mention it as what? As a 5 contagious or 8 non-contagious. What do we mean about it? 8 non-contagious يعني معناتها 4 هنا و4 هنا. Okay. طيب stages. Stage 1 demarcation line. Stage 2 retinal ridge. Stage 3 new vascularization. Stage 4 and 5, it is detachment. This is partial detachment. This is total detachment. And this is an illustration of it. So this is stage 1, demarcation line. Stage 2, there is a thickening of this demarcation line. Thick. Stage 3, there is a new vascularization over this demarcation line and ridge. Stage 4, there is a detachment, fibrous tissue, and detachment with the macula is not improved. It's a partial detachment. Stage 5, this is a total detachment. This is the retina and this is underlying tissue. And this is total detachment. Only the optic nerve is remaining. طيب يعني لما نقول إنه مثلا stage 3 اللي هي هذه neovascularization. طبعا stage 1 and 2 no treatment, just observation. Just close observation. Stage 3, treatment. And the stage 3 treatment by what? By injection or by laser. Stage 4, surgical. Stage 5, end result, surgical, لكن success rate is very, very, very poor. And the prognosis in this stage is very worrisome. And the problem of ROB patient, they are extremely premature and babies. They don't complain. And the other important thing, it is a bilateral condition. It is not only one eye, it is both eyes. So if anything happen and missing these babies and it is a progressive disease, you will convert a normal baby to a blind baby. And that's why it's a very crucial and very important disease. The treatment is easy, the prevention is easy, the screening is easy, but the complication if happens, it's the end result of this baby. طيب. Plus disease, it's a part of sub-classification of the stages. يعني either stage 1 or 2 or 3, it can happen with plus. So plus is an additive. وش معناته plus? Plus, presence of plus disease is an ominous sign. It is a feature. لما تكون في arteriolar tortuosity or venous engorgement of the posterior pole, iris vascular engorgement, poor dilation, pupillary rigidity, and that's why they will have poor dilation, vitreous haze, if they have a dense and if they have vitreous hemorrhage. So these are the features. If this is added to stage 1 or 2 or 3, this is what we mean about threshold disease. So what is the meaning of threshold disease? Is 5 or 8 cumulative clock hours of stage 3 with a plus disease in zone 1 or zone 2. This is the stage that in it we need to intervene and to do a treatment, either with laser or with injection. Treatment option screening is crucial. Medical treatment like laser injections, surgical treatment vitrectomy plus versus buccal, and early treatment for ROP study. This is the study that we follow in our country. طيب. Thank you. I think and we have a lot of questions maybe. Clear؟ ولا ما أتوقع؟ ولا سهل؟ The rule of oxygen supplement as a risk factor here is the same rule in what is it? Rule in retrolental fibroplasia. No, retrolental fibroplasia is the end result of stage 5. Retro معناتها behind, lental معناتها lens. Fibroplasia, this is the old nomenclature of this end stage ROP actually. End stage ROP ثواني. This one. They mention this and they given this name because before they don't know what happens. Before, I mean, at the early stages of ROP, maybe more than 100 years. So they mention this as a retrolental fibroplasia. They don't know what's happening. There is a fibrous tissue and there's a whitening behind the lens, and the baby does not see. What happens, they don't know. So that's why they given the name of a retrolental fibroplasia. Of course, we don't need to be reaching this stage, because in this stage, we don't have anything to do with actually. Can we repeat plus disease? طيب. Plus disease ominous sign معناتها it's a poor prognosis. say plus disease معناتها it's a feature inside the retina يعني inside the blood vessels. If you see like these vessels, tortuous, engorged, hazy view, pupil is rigid, does not dilate, this is the sign of plus disease. It's not stage. It's a sign بس. نضيفها على السtage اللي موجود. How you can diagnose the disease? Examination, screening. And that's why we mention اللي هو inclusion criteria for the screening of the baby. It's very important when you screen the baby. يعني all babies they need screening. No طبعا. لكن there is a screening protocol and there is inclusion criteria for the screening protocol. What are these? If the birth weight less than 1,250, if the gestational age less than 32 weeks, if the weight is less than 2,000 grams with certain condition, if it is long duration with an ICU admission oxygen supplement, although the age is more than 32 weeks, or if there is a coexisting cardiopulmonary congenital disorders. So all of these inclusion criteria for screening to rule out ROP. واضح رغد؟ Welcome. Is it clear? Okay, so we'll go through the next topic, or you want a break of 5 minutes, whatever. Okay. طيب next topic اللي هي الuveitis. Uveitis and painful and red painful eye. Okay, differential diagnosis of red painful eye. طيب. In general, if the patient presenting to, for example, this will take it as an emergency conditions, and the patient will present with redness and pain in the eye. So you need to take it seriously. Sometimes it is a serious condition like this one, and sometimes it is not a serious condition, okay? But if the patient having a painful red eye, most likely this is an emergency, okay? The differential diagnosis of a red painful eye, including corneal ulcer, acute uveitis or iritis, acute congestive glaucoma, which is closed angle glaucoma. Open angle glaucoma does not result in emergency. لكن although it is important to know it and to diagnose it, لكن the glaucoma that is presenting acutely are two conditions, mainly the closed angle, whatever the closed angle, either pupillary block glaucoma or a neovascular glaucoma. Corneal ulcer, endophthalmitis, هذه including uveitis. طيب, usually one eye, it can present both eyes, often decreased vision, distorted vision, not decreased vision, إلا إذا كان involvement with the posterior pole and the retina and the macula. Eye pain, moderate, maybe it is very severe, like in VKH, light sensitivity, yes. They will have a photophobia. In uveitis, discharge, it is a watery discharge. In corneal ulcer, it is not watery, it is purulent or mucopurulent. In conjunctivitis, it is mucopurulent or purulent or mucoid. It's sticky, depending on the underlying condition. Either it is viral or bacterial, and which viral is involved in this conjunctivitis. The conjunctiva, it's a generalized redness. In corneal ulcer, it is around the macula, which is what is called ciliary injection. In uveitis, the same, it's around the cornea. In acute congestive glaucoma, it's around the cornea. The cornea in conjunctivitis, it is normal. Here, it is normal, clear. Here, it is hazy because of the fluid in the epithelial layer of the cornea. And here, it is very gray. Here, it is, in corneal ulcer, it is very distorted. Anterior chamber, here, it is normal. And here it is flat, but is normal. There is no cells in the anterior chamber. The fluid is clear, but here it is variable. Here it can result in +1, +2, +3, +4 cells. Sometimes hypobion. This one is acute iritis, which is a mild subtype. This one is very severe. And corneal ulcer is a very severe anterior chamber reaction. هذه جتكم في الإكزام أمس صح؟ توقع جاكم انفلتريت امس؟ اوكي كويس. كيف كان سبوت اكزام امس؟ اكسلنت جود. طيب في احد ما كان مبسوط من الاكزام؟ كلكم اللي يردون كانوا مبسوطين طبعا. عدم مجيد. yes, this is hypobion. excellent. طيب البيبل سايز ممتاز عبد الله. The pupil size normal or round in conjunctivitis. This is normal, and this is small irregular. This is mid-dilated oval. Pupil response to light, it's active, except these two conditions, glaucoma or uveitis. It is minimally reaction and small. This is sometimes does not react in acute conjunctive glaucoma. Intraocular pressure, this is variable, and this has to be normal, and this has to be normal, and this is, of course, it is stony hard. This is very high, more than 45 or 50 around. Photophobia, it's present in this one and this one, and also this one. Useful diagnostic sign and test. This is full examination they need, and this is full examination with scraping for stain and culture, and this is swab for stain and culture, and this is checking the intraocular pressure. We'll go, we wouldn't go through all of these, we'll go just the uveitis. The objective of uveitis is to know what is it, etiology, signs, symptoms, classification, diagnosis, systemic associations, as well as treatment. Definition, it is a generic name, it's a broad term referring المقصد في الuveitis, referring to any inflammation of the uveal tissue, اللي هي الايرس, ciliary and the choroid, more precise terms including iritis if there is inflammation of the iris, iridocyclitis if there is inflammation of the ciliary body, vitritis if there is inflammation of the posterior segment including the vitreous. But there is no inflammation of the vitreous. It is just a spill over in the vitreous, like anterior chamber. Retinitis, yes, if there is inflammation in the retina. Choroiditis, vasculitis, if the inflammation involving special tissue in the retina, and choroiditis if it is involving the uveal tissue and in the choroid. So it is not only inflammation of the uveal tissue, it is inflammation inside the eye, except keratitis and scleritis. So an inflammation inside the eye is given the name of uveitis. Okay, either iritis, iridocyclitis, retinitis, vasculitis, choroiditis, all of these. Etiology, either traumatic, resulting in acute iritis, infectious, autoimmune disease, idiopathic, 40% of the cases is idiopathic, masquerading disease, in oncology cases like retinoblastoma. Clinical presentation depend on the type and the location of uveitis. Classification of uveitis, we'll go through the classification before the presentation, okay? So the classification, either anterior, intermediate, or posterior, or panuveitis if it is involving two parts. What do we mean about anterior, intermediate, posterior? Anterior, the landmark is the lens. So if it is anterior to the lens, this is anterior uveitis. If it is posterior to the lens and anterior to the retina, this is intermediate uveitis, يعني vitritis or paraspanitis. And posterior, if it is reaching the retina or retinitis, vasculitis, choroiditis, this is posterior uveitis. If it is involving two layers, posterior, intermediate, intermediate, anterior, anterior, posterior, this is called panuveitis. أشهر مثال على panuveitis in our country is, what is the rheumatological disease that is resulting in uveitis? انتم اخذتوا الميديسن صح ولا ما اخذتوا؟ طيب بالباثولوجي اول اخذتوا الباثولوجي صح؟ في البيسك ساينس، يعني قصدي في السنوات الاساسيه. طيب what are the اللي هو الفاسكولايتس او rheumatological disease that you know it actually, whatever that you know it. What are these? Rheumatoid arthritis, yes. Ankylosing, what غيره? Excellent, Abdullah. So rheumatoid arthritis, SLE, polyarthritis nodosa, rheumatoid arthritis. Okay. So you know rheumatoid arthritis. Rheumatoid arthritis never will result in uveitis. It will result in what? What is the association with the eye? Excellent, Hussam. So scleritis and sclerokeratitis, and it is severe scleritis. And there are different types of scleritis, but this is resulting in what's called scleromalacia perforans. Scleromalacia perforans is a very severe scleritis resulting in perforation and eating of the sclera. This is associated with rheumatoid arthritis, yes. What else? What are the other conditions that you know it other than rheumatoid? SLE. SLE does not result in uveitis. It can result in uveitis, but extremely rare. And the most important association with it is a soft exudation in the retina. What else? What else that you know it? It's a common actually. No, not infectious. It's non-infectious. غالبا في الميل presenting with a recurrent oral ulcers and ankylosing spondylitis. Yeah, it can result in HLA-B27. AIDS. Bahjet. Excellent, Noura. So Bahjet is one of the leading uveitis in our country, and it is a blinding condition because it does result in retinitis. It results in a panuveitis. It results in a bilateral panuveitis. It's a very severe condition, treated with immunomodulatory medication like infliximab and Humira monthly injections. It is a very severe rheumatological disease associated with uveitis. It's a Bahjet. طيب, features of Bahjet. Noura, what are the features of Bahjet disease?
Oral ulcer.
What else? What is the typical scenario that the patient will present with? How do you think?
اللي يتذكر دكتور جس اللي هو الألسر إنه recurrent ulcer.
Excellent. So any other thing that can result in recurrent oral ulcer? طيب, what are the features of this oral ulcer? طبعا oral ulcer, it's a common. It's not alone we can diagnose as Bahjet disease. لكن there is a special feature in oral ulcer in Bahjet disease. What is this? What do you think?
Maybe painful.
Excellent. It's a very painful that he cannot talk, he cannot eat. And coming in middle-aged male at least 3 times per year, and takes around 1 to 2 weeks, and resolves spontaneously without any scarring in the mucosal area afterwards. Yes. واضح? In addition to that, they will have what? They will have genital ulcer also. Not only oral ulcer, it's a mucosal ulcer at the moment. It's a junction between the skin and the mucosa. So the mucosal, the junction of the mucosa and the skin, this is the area that they will have it, the ulcer there. So they will have oral ulcer, genital ulcer, recurrent, at least 3 times in a year. Okay, this is gold standard. This is, if there is no oral ulcer, no Bahjet disease. You can rule out Bahjet disease without oral ulcer. So it has to have the patient oral ulcer. طيب, عندنا anterior intermediate posterior panuveitis, acute versus chronic granulomatous versus non-granulomatous, infectious versus autoimmune versus sporadic disease. Granulomatous non-granulomatous will go through it. This is a classification. طيب, نرجع نشوف clinical presentation depend on the area. Is it anterior, intermediate, or posterior? And that's why we go through first the classification and then we go back to a clinical presentation. So for anterior uveitis, the patient will have pain, redness, photophobia. If it is intermediate, the patient will have floaters and decreased vision only. either intermediate or posterior, the same presentation. Anterior, they will have a pain and redness. The signs of the anterior, they would have cells and flare in the anterior chamber. The anterior chamber fluid, the aqueous fluid, wouldn't be clear. It would be turbid. And that's why cells are, and what are these cells? The cells are lymphocytes or macrophages and indicate active inflammation in the iris and cellular body. Flare is a result of protein leakage. So what you notice here, we said before, the cornea, the aqueous, the lens, the vitreous, and the fovea is devoid of the blood and devoid of any interruption to allow the light to pass without any destruction. Okay, طيب. Why the lymphocytes and the macrophages coming in the aqueous humor and the anterior chamber? Because there is what's called ocular blood barrier. It's, we mentioned before اللي هو origin of what? Of the retina and the periphery of the retina from where? From the neuroectoderm, صح? And that's why they will have like what's called the blood-brain barrier. We have also in the eye the retinal blood barrier. In general, it is ocular blood barrier. If this disruption happens, the cells and the flare will leak through these vessels and filling the anterior chamber, the aqueous and the vitreous. And that's why we'll see cells and flare in the anterior chamber. Keratoconus precipitates. This is a collection of inflammatory cells deposited on the endothelial surface of the cornea from the aqueous humor. Posterior uveitis signs like vitreous cells, retinal inflammation, vascular leakage, cystoid macular edema, exudation. These all, it's too much for you, I think. You have to know there are certain signs that is present in the anterior as well as in the posterior segment. طيب, classification, we mention anterior, you know it, acute and chronic, you know it, infectious, autoimmune, sporadic, you know it. But I think granulomatous, non-granulomatous, you know it from pathology. If there is granulomas, if there is epithelioid cells that is present in a microscopic picture, in a histopathological picture, like on examination, how can we differentiate? How can we know and how can we name and how can we label this condition as granulomatous, non-granulomatous based on certain feature that we can differentiate? طيب, we will go through one by one and then we'll see. The common uveitis entity that we have is the acute non-granulomatous anterior uveitis. And the most common group is idiopathic, most common cause of anterior uveitis. HLA beta 7, you mentioned about ankylosing spondylitis, reactive arthritis, Reiter syndrome, psoriatic arthropathies, and arthritis, inflammatory bowel disease like Crohn's disease that was mentioned by one of you, herpetic and Behçet. Okay, so Behçet and Behçet's, it can present either acute, intermediate, acute or chronic, non-granulomatous, granulomatous. It can mimic any conditions, but most of it is non-granulomatous uveitis, either anterior, intermediate, posterior, or panuveitis. Herpetic, like طبعا the most important اللي هو herpes simplex. Most likely it is herpes zoster versus cytomegalovirus. Herpes virus include what? What are the herpes virus that is under the herpetic family? Any idea? Excellent. So herpes simplex virus, cytomegalovirus. What else? Herpes simplex virus type 1, type 2, simple cytomegalovirus, zoster, herpes zoster, varicella zoster virus. Excellent. So herpes simplex type 1, type 2, varicella zoster, cytomegalovirus. Okay. So cytomegalovirus, it can result in uveitis. Yes. Herpes simplex, extremely rare, لكن it can. Herpes zoster, varicella zoster virus, yes, it can result. Okay. Zoster, it is a unilateral condition. Never, ever it happens bilateral. extremely reported, and there is certain underlying condition. لكن in normal speaking, by default, herpes zoster, it is a unilateral condition. طيب. Chronic granulomatous uveitis, like sarcoidosis, syphilis, TB, Vogt Koyanagi Harada disease. Okay. Sarcoidosis well known to have granulomatous, TB well known to have granulomatous, and Vogt Koyanagi Harada disease, it's well known also to have a granulomatous. In addition to that, there is sympathetic ophthalmia, and this is one of them, and can result in granulomatous uveitis as well as the syphilis. The presentation of granulomatous uveitis, this is illustrated picture of the clinical signs. If you're having chronic and acute will have what's called synechia. Synechia, it is an adhesion. Synechia, it is a fibrosis. And the end result of the inflammation is the fibrosis. So the fibrosis can happen early stage or later in the chronic stage. Okay, so the synechia is attachment of the iris to the lens. In this scenario, we called it as posterior synechia. If the synechia and the iris attached anteriorly, this is anterior synechia. Okay, this is a ciliary flush or ciliary injection or perilimbal injection. And this is the nodules. The nodules are the signs of granulomatous inflammation. So if we see on examination, there is a large collection of cells that is attached to the iris or to the periphery or on the surface of the endothelium of the cornea. This is in this stage, and in this scenario, we label it as granulomatous inflammation. And if we have a granulomatous inflammation, we will go through these differential diagnoses only. So if granulomatous inflammation, we need to diagnose it. If non-granulomatous and acute inflammation, 40% it is what? It is idiopathic. And it's self-limiting condition except for Behçet disease. طيب. The other signs like band keratopathy. Band keratopathy, we saw it in juvenile idiopathic arthritis, and juvenile we saw a lot of around 10 to 20% of these patients, they will have uveitis. Okay, and the classical picture. انت ما اخذتوا بيدياتريك صح؟ ولا لسه ما اخذتوا؟ انتم على طول دخلتوا في الاوفثالمولوجي يعني؟ انتي طيب. مشكلة الاوفثالمولوجي is related too much to the systemic condition, that's why. لكن اتوقع انكم يعني اخذتوها في البيسك يعني ساينس. لكن عموما there is a condition that's called idiopathic juvenile arthritis. Juvenile arthritis عموما. فالjuvenile arthritis associated with uveitis, and the picture of it is a painless uveitis. There is no synechia, there is no inflammation, but they will have a band keratopathy. They will have a whitening over the cornea. And this is classical picture of a chronic uveitis. طيب. Yes, Ali, and the inside the eye, and this is a case. For example, this one, just wait. This is a KBs. You can see the cornea, and these KBs, these keratic precipitate, it is inside the cornea. It's not over the epithelium, no, it is inside. And this is large KBs. It's called mottle fat KBs, large KBs. It's granulomatous uveitis. Here we mention about posterior uveitis. Posterior uveitis, we have three main conditions. One of them is Vogt Koyanagi Harada disease. You don't need to know about it. It's a detailed one. The other one is a Behçet uveitis. And the third one is toxoplasmosis. Toxoplasmosis in general in the body, it's a dilemma to diagnose it. It's difficult to be diagnosed actually. But in ophthalmology, it's very easy because we have a scar. Adjacent to the scar is inflammation and the infiltrate and the yellowish infiltrate, and there is what's called اللي هو vitreous precipitation. These are like the cavies, but is present in the vitreous. Okay, so retinitis adjacent to an old scar and vitritis. This is ocular toxoplasmosis, and the treatment as you treat toxoplasmosis. We are giving actually combination between clindamycin and cotrimoxazole, followed by steroid by 3 to 5 days to reduce the scarring and the inflammation and the inflammatory response. Complication of uveitis, glaucoma if they have synechiae, cataract with a long duration, retinal detachment if they have either exudative retinal detachment, which is more common, like invoked Koinagi-Harada disease, loss of vision, yes, if the patient is having detachment, if the patient is having glaucoma and was not controlled, if the patient is having, for example, retinal detachment with herpetic retinitis. طبعا herpes simplex and herpes zoster, it can result in anterior, and we mention it here as anterior uveitis as herpetic, but herpetic, it can present with retinitis. And if this herpetic resulting in retinitis, herpetic retinitis, it will be very severe condition, and we don't see it in the usual normal healthy human being. We see it in immunocompromised patient, whatever the cause is that. And this is resulting in herpetic retinitis with severe retinal inflammation, multiple breaks, retinal detachment, and the prognosis is very, very poor. Paget disease, if resulting in inflammation like this one, this is retinitis, but this is toxoplasmosis. Paget, it can result in like this inflammation, but it is in the fovea. This is nasal to the retina. It will be in the fovea. So if it will be in the fovea, it will destroy the fovea, and that is the Paget disease. Paget disease involving the macula. This is at that stage we need to intervene immediately, and we start on IV, actually steroid, followed by oral medication like Silsibt, cyclosporine, and monthly injection with immunomodulator medications. What was the question? I think, no. Yeah, this is a communication. I think we are done. There were a question. What is this? Abdullah? Bahjat, you mean? Yes, Bahjat, yes. Yeah, it can present uni or bilateral. Toxoplasmosis, it can present unilateral if it is acquired, bilateral if it is congenital toxoplasmosis. I think we are done. Any question? Should we know the details in slide 3? Slide 3. لا, of course no. This is just as guidelines. And if you know it, it's good. If you don't know it, no need. I think remaining one. أتوقع إنه في باقي. حياكم. في باقي lecture صح؟ حياكم الله. بس باقي الظاهر دقيقة. Examination, yes. Examination, just I think it's two slides only. for retina either by anterior by the slit lamp. We are using the condensing lenses like this one. Retinal disease were a little bit harder than the other two. بس لما ترجعون عليها أتوقع إن شاء الله تعالى بتكون واضحة. الإيميل موجود عندكم، رقمي موجود عندكم في أي وقت، حياكم الله لو في أي أسئلة ولا حاجة. بس إن شاء الله تعالى إنه واضح. في الإكزام بتكون في أسئلة، وفي أسئلة أتوقع إنها يعني شوي صعبة، بس إنها informative وأتوقع إنها كويسة إن شاء الله. طيب في الإكزامينيشن we are examining by direct. هو فندس، والفندس examination عموما هو retinal examination. فالفندس examination either direct examination or indirect examination. In direct examination we are using this